You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for May 10th, 2019. This week, from San Francisco, spin in the cardiovascular literature, palliative care, TPA for stroke, and ablation volume in hospitals. The first topic is spin in the cardiovascular evidence base. And the first thing I want to say about the following paper is that I was an author on it. Dr. Shahzeb Khan at the John Stroger Jr. Hospital of Cook County was the primary investigator, and Dr. Richard A. Krasuski from Duke was senior author. I'm proud to be on this paper that systematically reviewed the cardiovascular literature to assess the level and prevalence of spin from randomized controlled trials published in the literature. Recall that an RCT is an experiment. It has methods, a pre-specified endpoint, results, and a conclusion. Spin has been previously described from other areas of medicine, and it occurs when the authors first pivot to statistically significant secondary results, such as within-group comparisons, or secondary outcomes, or subgroup or per-protocol analyses. Spin also occurs when authors interpret statistically non-significant results of the primary outcome as showing treatment equivalence or ruling out an adverse event. And another way authors can spin is to emphasize the beneficial effect of the treatment with or without acknowledging the statistically non-significant primary outcome. The results of our systematic review included RCTs from 6 high-impact journals from 2015 to 2017. This included New England and Lancet and others. 93 RCTs met the inclusion criteria, and spin was present in at least one section of 53 or 57% of the abstracts. Spin was found in 62 main text, or 67%. And get this, in nearly a third of abstracts and nearly 1/5 of main text, spin was observed in all sections. And about half the conclusion sections of these papers included spin. Now, Patrice Wendling from the Heart.org Medscape Cardiology has a superb news recap of this story. And to be honest, she actually pointed me to this study when Dr. Khan first presented it at AHA. Then I went and talked with Dr. Khan, and we got to talking, and he asked me to help him write the manuscript. And I'm happy to participate in this sort of work because it addresses one of the core principles of evidence-based medicine, and that is the translation of evidence to the bedside. Our conclusion, I really like our conclusion, and it speaks to this issue. We wrote, in cardiovascular RCTs with statistically non-significant primary outcomes, investigators often manipulate the language of the report to detract from the neutral primary outcomes. And to best apply evidence to patient care, consumers of cardiovascular research should be aware that peer review does not always preclude the use of misleading language in scientific articles. Next topic is palliative care. I gave a talk Wednesday here at the Heart Rhythm Society on end-of-life discussions in patients with ICDs. The first part of my talk showed the current evidence base, and it's not good. Cardiologists do not do well at preparing our patients for the inevitable. My very first slide showed a recent study, just a week or so ago, published in JAMA Network Open, looking at characteristics of patients with heart disease who are referred to palliative care. The famous Haider Warrick, he's an author and Duke doctor, and other colleagues from Duke looked at registry data on 1,800 patients with heart disease who presented for a first visit to palliative care from the years 2015 to 2017. This was a registry study, and it encompassed many care types, like from academic to private, urban, rural. And they had 4 main findings. First one was shocking. Nearly 30% of patients first referred, had bedbound status. The proportion of referrals from general medicine increased over the 2-year period from 43 to 53%. That's pretty good. but the proportion of referrals from cardiology decreased from 16% to 10%. Those are low numbers. And fourth, finally, substantial proportions of patients in this study reported moderate to severe symptoms, including poor well-being in over half, tiredness in over half, anorexia in a third, shortness of breath in a third, and pain in about 20%. And this data confirms previous data showing that heart failure patients suffer from a lack of palliative care at end of life. As part of my talk preparation, I read an excellent textbook on palliative care in heart failure by British authors Miriam Johnson, Richard Lehman, and Karen Hogue. I'd highly recommend this textbook. Another slide I took from this book was that the symptom burden in patients with heart failure is nearly identical to the symptom burden in patients with cancer. But for some unknown reason, consultation with palliative care in cancer seems less taboo than it does for cardiology. I'm not sure why that is. Another slide I showed in the talk was the PAL heart failure trial. This is PAL-HF, PAL heart failure RCT, which found that palliative care plus usual care resulted in improved scores on quality of life metrics. The main point, one that my wife Stacy drills into my head, is that palliative care should run concurrently with normal heart failure care. Somehow, cardiology has to do better for our patients with advanced heart disease. We have to remember that mortality is not the only important endpoint in cardiology. Next topic is TPA for acute stroke. Here we go again. TPA and acute stroke and spin in trial manuscripts go together like peas and carrots. The Extend trial, published in New England Journal, first presented this winter at the International Stroke Conference in Hawaii, was an RCT of TPA versus placebo in stroke patients who had hypoperfused but salvageable regions of brain detected on imaging. The Extend hypothesis was that given TPA between 4.5 and 9 hours after stroke onset, or on awakening with stroke symptoms, for which the time of onset would not be known, would provide a benefit in patients who had a small core volume of cerebral infarction that was disproportionate to a larger area of hypoperfusion. Extend randomized only 225 of the planned 310 patients because the Data Safety Monitoring Board recommended stopping enrollment with publication of the Wake Up trial because their interpretation of the Wake Up was positive and thus that there was no longer equipoise. Now, Wake Up was hardly positive, but let's first discuss the findings of Extend in these 225 patients. The primary outcome, which was a score of 0 to 1 on the modified ranking scale, occurred in 35% in the TPA group versus 29% in the placebo group. And the adjusted risk ratio was 1.44, and the 95% confidence intervals ranged from 1.01 to 2.06, and the p-value is 0.04, so just barely positive. But balanced against this quote-unquote benefit in subjective terms, note that the modified ranking scale is highly subjective and known for its variance amongst neurologists, was a six-fold higher rate of symptomatic intracranial hemorrhage. Now let's take the patient view of this data. You're having a stroke, and you present late with what looks like salvageable brain on the MRI. Your chance of benefit from TPA is about 1.44 times. Your chance of being seriously harmed by intracranial hemorrhage is greater than 7-fold. Now, this doesn't stop the senior investigator from Extend from saying this, quote, "These results open up the possibility of treating many more stroke patients with thrombolysis," senior author Jeffrey Donen from Australia told Medscape Medical News. This sort of spin was also seen in the Wake Up trial. Wake Up was a TPA versus placebo trial in patients who had an unknown time of onset, but an MRI that suggested time of onset less than 4.5 hours. In the Wake Up trial, the point estimate for benefit was a little greater at 1.61, but there were 10 versus 3 deaths in the TPA versus placebo arm, and the hazard ratio for symptomatic intracranial hemorrhage here was nearly 5-fold in the TPA arm. Ladies and gentlemen, The TPA for stroke story continues to amaze me. I have looked at this data up and down, and I'm working on a meta-analysis on this issue. But having looked at the data carefully, I would 100% refuse TPA if I was having an acute stroke. There is just so much asymmetry. If there is a benefit, because the hazard ratio always toggles the null, it has to be balanced against a consistently higher rate of symptomatic intracranial hemorrhage. Now, what's even crazier about this is that the entire stroke industry's apparatus revolves around this very, very unconvincing data. Next topic, AF ablation centers. Now, everyone would agree that operator experience matters a lot for AF ablation. But doctors do not work in isolation. We work in hospitals with teams of people. Does hospital volume make a difference on outcomes? Dr. Jim Chung from Weill Cornell Medical College and colleagues examined outcomes after AF ablation stratified by hospital volume. They extracted data from the nationwide readmissions database between 2000 and 2014. This was presented as a featured abstract here at HRS. Sit down for some of this data. In the United States, nearly 80% of centers did fewer than 20 ablations per year. Pause on that for a moment. Fewer than 20 ablations per year. That sounds awful, but this stat is worse. 63% of the total did 10 or fewer ablations per year. Not surprisingly, overall complication rates were higher in the lower volume centers, and it ranged from 8.9% down to 4.5%, and this was all statistically significant. Lower volume hospitals were independently associated with a twofold higher rate of any complication and early mortality, and a fivefold higher rate of cardiac perforation. Now, also unsurprisingly, veteran journalist Steve Stiles noted that across the board, the patients who were treated at lower volume centers were also older and sicker. They had more coronary disease and more congestive heart failure. Of course, as is always the case in these observational analyses, the authors try to adjust for these comorbid conditions, and even then, the rates of complications were higher in low-volume centers. So you know the drill. This is observational data derived from a database. You can't tell whether the low volume is causal in the higher complication rate. But it's surely plausible that lower volume centers result in worse outcomes just on the basis of experience. So with really, really great caution, I dare say that this study, along with many other similar studies looking at other types of cardiac procedures, supports the Canadian model of doing specialty procedures in small numbers of hospitals so that only high-volume centers are doing the work. That's not the case in the U.S. In the U.S., there's many, many hospitals doing AFib ablation. And you can make an argument to expand, say, STEMI care to lots of hospitals. But rapid access to AF ablation is not only unlikely to affect health, it could even be that the more access to AF ablation, the worse population health would be. Finally, I will cut it a bit short today as I am at the HRS meeting in San Francisco. I have 2 columns I just sent in. They're coming up soon. One is a summary of my talk on why we need a sham control trial for AF ablation, though I do prefer the term placebo-controlled trial over sham. Another one of my columns centers on my newfound participation in clinical research. Yesterday, Rod Tung from the University of Chicago presented the HIS-SYNC trial as part of the late-breaking clinical trial session. I was honored to be a co-investigator in this trial, but what I learned from the experience is that research is darn hard. Not just in getting the research done, but then in dealing with the emotions when the results don't quite come out as you had thought. Heart Rhythm Society meeting here is incredible. General cardiology meetings may be shrinking, but I don't see that here. This place is booming with electrophysiology people. Next week on the podcast, I will have a proper recap of the Heart Rhythm Society meeting. And once again, to those of you who come up to me and told me that you listened to the podcast from all over the world, I say thank you to the power of 10. This means so much to me. So as always, I'm grateful that you listened. Thank you. This is John Mandrola from the Heart.org Medscape Cardiology.
You're You're listening to This Week in Cardiology from theheart.org on Medscape.